Hello, in this video I will be talking about de novo metastatic breast cancer. Before I go on, I'd love to invite you to subscribe to our channel. We're always putting out new content, so there's always something new to watch. What's de novo metastatic breast cancer? Well, technically it means of new. So it means that people are diagnosed with advanced cancer at the very first time they're diagnosed with breast cancer. So they may have a lesion in the breast, a tumor in the breast, and they also have disease in other parts of their body. So the way this is diagnosed is one of two ways. Somebody will have symptoms that I'll go into in just a moment, and then they're found to have a breast cancer. Or the breast cancer in the breast itself is found, and then they also, at the same time, are found to have breast cancer cells in other parts of the body. How often does this happen? Well, we generally have seen this over centuries occur in 6 to 7% of people with breast cancer. And there are really two types. There's the type of cancer where the disease in the breast has been there quite a while, and often the person will know that it's in the breast and they won't seek medical attention. And then when they do, it's found to be in the bone or liver or lungs or brain. And then the other type is people who come in with symptoms in the liver, lungs, bone, or brain, or really anywhere else, and they're found at that time to have a breast cancer lesion. So there's sort of two types of people, one where the cancer's been there and it's been sort of ignored, and then there's the other type where people come in right away with symptoms in other parts of the body, and they're then found to have a breast cancer. The prognosis is pretty similar for both. So as I mentioned, this is seen in about 6 to 7% of people with breast cancer, and it's been pretty stable over the last decades to a century. How people show up is one of those two types, and I'll describe the symptoms of disease in the liver, lung, breast, brain, or elsewhere now. So if symptoms show up in the brain, people will have headaches or sometimes seizures. They might have weakness on one part of the body or vision problems. If it shows up in the liver, they might come in with jaundice, or they might have pain in the upper right quadrant of the abdomen, which is on the right side near the ribs. In the bone, people can come in with bone symptoms like bone pain, or occasionally a fracture in the bone, like a spinal fracture or a fracture in the femur, which is the long bone of the leg, the hip area, or the ribs sometimes. And in the lungs, they can present with fluid around the lungs or with shortness of breath because of fluid around the lung or because there's cancer in the lung. The way it's diagnosed is with scans or an evaluation of the area that's painful, and often a biopsy. We do like to do a biopsy of any area we think is breast cancer because sometimes it's another kind of cancer and it really matters where the cancer is coming from. There are some people in whom we can't do a biopsy of the other parts of the body because it's just difficult to access, or because it's very clear that's what's going on. But in general, the standard of care is to get a biopsy, not only of the breast and the lymph nodes, but the other parts of the body where we think breast cancer has developed. What causes de novo metastatic breast cancer? In general, it's the same as what we see in people with breast cancer at any stage. So genetics, increasing age, being a person with ovaries, sometimes it's other risk factors that we know are associated with breast cancer, like diabetes or overweight. But in general, it's the same profile as we see in people with any stage of breast cancer. How do we treat de novo metastatic breast cancer? Well, as with all breast cancer, we use multiple modalities. We will use systemic therapy first in most cases because people have symptoms and we want to treat the whole system. So we will focus on things like endocrine therapy, chemotherapy, targeted therapy, PARP inhibitors, depending on the type of cancer and the markers that people have. So it depends a lot on where it is in the body, but also on things like estrogen and progesterone receptors, HER2 status, whether or not somebody has a BRCA or BRCA mutation, and also on their symptoms. If somebody has a low volume of disease, it's not filling their body and it's estrogen and progesterone receptor positive, we will almost always go with endocrine therapy first because it's highly effective, fewer side effects. If they also have the HER2 protein or gene, we will use hormonal therapy, sometimes with targeted therapy. We try to minimize symptoms because this is really advanced disease, and the goal of treatment is to control the disease and to help people feel better, to prolong survival, but in general, we don't aim for cure. About 5% of people will have a long-term disease-free remission where we can treat the disease elsewhere in the body and in the breast, and at that point somebody might have surgery or radiation therapy if indicated. But we're not attempting cure out of the gate. We're attempting to improve quality and longevity of life. Surgery for de novo breast cancer may be offered if people have a great response in other parts of their body. So the bone disease, the liver disease, the brain disease are all treated and essentially heading towards a remission, whether it's partial or complete. And then we want to control the disease in the breast and the lymph nodes. We generally won't do surgery until we've shown that the disease in other parts of the body is responding. Why is that? Well, doing surgery and decreasing the amount of disease in the breast or the lymph nodes won't improve outcomes unless we can control disease elsewhere in the body. And that same disease, the same treatment that controls disease in the rest of the body will also treat the breast and the neighboring lymph nodes. I'm hoping that makes sense. If it doesn't, drop a comment or a question below. It's a little counterintuitive. We're taught that treating the disease early, removing it from the body is the best thing to do. But in this case, where cancer's in other parts of the body, the big priority is to treat disease in other parts of the body so that it won't be life-threatening or life-altering. We want to get that under control and then maybe control the local disease as well. The other key things are if somebody's diagnosed with breast cancer and it's already spread to other parts of the body, that is, this is stage 4 disease, you want to make sure that appropriate genetic counseling and maybe testing are taken part in. We don't say, oh, it's stage 4, therefore it doesn't matter. If somebody has a genetic mutation, it absolutely does. Other prevention strategies for you and your family members might be appropriate. And also there are treatments that depend on whether or not you have a BRCA or other mutation that increase your risk for breast cancer. So there's a lot of things to think about. The key is let's control the systemic disease, then treat the local regional disease and take care of the rest of you. So symptom management's really important. Bone-directed therapy would be important. Making sure we're taking care of all the rest of you as well. It's really important to know we treat the person, not just the disease. And in fact, one would argue the person comes first and not the disease. I hope this has been helpful. I covered a lot. Make sure you drop your comments or questions below. Follow us on Instagram. Don't forget, you can go to yerbba.com for your personalized report and share this with someone you think it might be helpful for. Thank you for watching.